Hello, everyone, and welcome to One Healthy Boston's Facebook Live. I'm Kristen Perfettio. Did you know that more than 70,000 babies are born every year here in Massachusetts? And that means that parents and parents-to-be have thousands of questions about what to expect before, during, and after delivery. And that's why I'm joined tonight by Dr. Kim Dever. Dr. Dever is Vice President of Medical Affairs, as well as the Chief of Obstetrics and Gynecology Department at South Shore Health. Dr. Dever, in addition to that, has also helped spearhead the Team Birth Project, which is a program that has been spearheaded by South Shore Health, and it has helped improve the childbirth experience. So we want to welcome our viewers at home to send in any of their questions related to pregnancy, before, after, during, and Dr. Dever is going to do her best to address some of those questions tonight. So welcome.
Thank you, Kristen.
We're so excited to have you here.
I'm so excited to be here.
Oh, good. We're going to get right to Team Birth. It's been such an integral part of our maternity department at South Shore Health. Can you talk about what that is and how it has helped the childbirth experience?
Absolutely. So we embarked on the Team Birth journey last April. So it's been, 15 months. The way it started is, for a long time, we've really looked at the way we deliver care and felt like we're doing a great job, but how can we make it better? And one of the big areas that we identified that we thought we could do better was our C-section rate. Like most hospitals, the C-section rate has gotten increasingly higher over the past few years. So we had a number of efforts. We really tried to say, okay, let's make sure that those necessary cesarean sections can happen, but if it's not necessary, is there anything we could do differently? So we had the opportunity to partner with Ariadne Labs. Ariadne Labs is a think tank out of the Harvard School of Public Health and Brigham and Women's Hospital. Mm-hmm. And they came to us with the Team Birth Project. They were looking for a pilot hospital to partner with, to be able to change the way we communicate with women in labor using very simple tools. The idea of the projects that Ariadne does, that you want them to be simple and that they could be spread across, lots of hospitals.
Okay.
So it's a very simple approach where we really change how we communicate with women in labor, and we use some standardized discussion tools to help us decide when's the best time to admit someone in labor, are they really in labor, and when's the best time to decide, this labor shouldn't go on any longer, and maybe we should consider a cesarean section. So there's a whiteboard that allows us to communicate with the patient and her family members in a very different way, and then these discussion tools.
Okay, and again, the ultimate goal to begin with was to help lower that C-section rate, but what have you learned? Communication is huge, right?
We have learned that the C-section rate maybe will be a secondary gain, but what it has done, it has changed the experience women are having. It has made them empowered, made them feel safe, dignified, that their birth experience can be the very best, that they can feel like they were part of it. I tell women, you are going to feel like care was done with you, not to you. And that's so different than feeling like you come in and everyone's just sort of throwing things at you and telling you what's going to happen. It's like, no, you actually have a voice. You can make your preferences known. You can share why you have concerns, what your concerns are. And throughout the process, the team is keeping you informed on what they're doing, why they're doing it. Instead of the conversation happening in the hallway and then the team coming in, the provider and nurse saying, this is what we're going to do. It happens in front of the patient, with their family member. It's been amazing.
So it's really changing an old school culture, if you will, right? I mean, it used to be for years that doctor would come in and tell you exactly how you're going to have your baby, but now it's very much a team effort. Everyone has a say, including partner, correct?
Oh, absolutely. I mean, when we put the names on the board of who the team involves, number one is the patient, which again, a lot of the whiteboards that are used in hospital rooms, they put the name of the team, Nurse Sally, Dr. Kim, whatever. Where now it's like, no, who's the patient? Who's with them? We have heard repeatedly from the people with the patient, oftentimes the husband or father of the baby or other support people, that they were part of the process. We talked to them, we asked them, do they have questions? Sometimes in situations the patient may be, focused on breathing and can't really answer us or talk to us while we call them huddles. Every time the team talks, we call it a huddle. So during that huddle, that the support person feels like they're part of it. One of the husbands said to me, he's had a couple of other kids. He said, I felt like the other deliveries, I was like a child. I was supposed to be in the corner, seen but not heard. He said, this time I felt like you pulled me out of the corner and you kept talking to me, involving me. And they just touted how different an experience was and how much better it was for them as a couple and, for their family.
Talk to me a little bit about some of the tools that you used during this process. You mentioned a tool for helping to decide whether to admit, and then the whiteboard, and then the delivery decision aid, correct? Exactly. Kind of walk me through what those are.
Okay, so the first one that we can involve in the care of the patient is a discussion tool about when to admit the patient. One of the things, studies have shown that if women are admitted too early in labor, that their risk for cesarean section is much greater.
Okay.
There was one study that said if women are admitted early in labor, early being less than 4 centimeters dilated, they have an 18% higher chance of a C-section.
No kidding.
If you're admitted later, meaning 4 centimeters or greater, it goes down to a 4% chance. So, again, these are the types of cesareans that are not really necessary. Again, if it's an emergency, we all agree. There's something wrong with the mom, the baby. We're not talking about those situations. But in a situation, the mother comes in, she says, I think I'm in labor. We evaluate her, and we don't think she's in labor. This tool helps us discuss with them why. Well, you're doing fine. You're safe. Your blood pressure's good. You're maintaining your pain control. The baby's safe. We're monitoring. Everything looks good. And your labor progress, and we focus a lot on the mom, the baby, and the progress throughout this whole journey.
Okay.
The progress isn't where we want it. You're not yet dilated far enough. So we don't have to admit you. We could have you use one of our spaces for early labor. We have an early labor lounge. The woman can walk around, use a yoga ball. And other women, we offer them the opportunity to go home, especially if they live close. So that's that decision aid or discussion aid for admission.
Okay.
Then the next aid comes in if they're in labor or if there's a reason to keep them. Once they get in the room, we have a whiteboard. And again, it's very simple. It literally was a piece of cardboard that we had printed. Now we've made them kind of nice and pretty to fit our, because we're sticking with this. It's kind of like these are the final ones.
Yeah.
The first area is who's the team? So again, it's the patient, their support people, the nurse, and then the providers.
Okay.
The next section is her preferences, or the preferences for her experience. And that has been crucial, where you really want to listen to the mom, or if they have that kind of plan in mind of what they want.
Mm-hmm.
Very often they're simple things like, I want to try to avoid pain. I want an epidural. Or other women, I'm going to try to do this naturally.
Okay.
Sometimes there's more in-depth preferences of things they want. They want to have the baby on them and do skin to skin. They want to breastfeed immediately. I mean, whatever their preferences are.
Yeah.
Sometimes it's fun things like the dad wants to be the one to yell out if it's a boy or girl.
Yeah.
Or he wants to be the one to tell us the name. I mean, whatever it is.
Mm-hmm.
And we encourage the patient, if we leave the room, feel free to add to that. You might not have thought of that when we're in front of you, but if you think of something when we're not here, that's what the marker's for.
Okay.
Then the next part is the progress piece, where we always have on there kind of what we're expecting for the mother, the baby, and her progress of labor. Like, what's the plan for each of them? And then we have a piece that says, when are we coming back? When's the next huddle? I used to joke and say to the nurses, probably the first thing the patient said every time I'd leave the room, they'd say, when's she coming back?
Yeah.
Because I'd oftentimes say to the patient, do you have any questions? Okay, I'll see you later. And I'd walk out.
Yeah.
And then the patient...
Then it's sort of like,
And a number of patients have also said that board really made them feel like they remembered everything, because again, so often in front of the doctor and the nurse, they're this whole process is overwhelming. They forget, and they'd kind of say, what did they say? And they can look at the board. Oh yeah, she said we're going to do this next, and if I haven't made a change in my cervical dilation, I'll start this medicine, or I can have the epidural then. I mean, it's something they can almost give them a sense of control, because I, having gone through labor and birth a few times myself, it's a very out of control situation. So patients have just found, I think, that they like that sense of control and that sense of open discussion and conversation. And then the final tool is the delivery discussion aid.
Okay.
And again, I try to use it throughout the process so that they understand why we're making decisions during the labor, and if they're not going a certain way, why we might do other things.
Okay.
But I think very often, especially if, say, the labor's not progressing, you've done everything that this aid kind of helps the patient understand why you're doing. You've used medications to try to augment the labor, you've had them get up and move, we've done positioning, like nothing's helped. It is a way for them to see that path that you've been on that journey.
Yeah.
And so again, I find it's just a way. It's not there to tell me what to do. I hopefully know what to do. It's not there to, have the patients sort of say, okay, you're following the protocol. It's just another tool that they can then understand. And we leave it for them so that they can look at it and read it. But it's, again, kind of a standardized approach.
And then if you do have to have a necessary C-section, they sort of have been brought along that journey and understand why, in the end, you have to go that route, correct?
Oh, absolutely. Yeah. I've been, an OB for a number of years, and very often a patient will come in with like a subsequent pregnancy. And I'll say, well, why did you have a cesarean section? Say if they had a C-section in the past. And they'll go, oh, I don't know, they just told me I had to. Then I get the records and I read it, but it's always fascinating, and that's okay if they're comfortable with that. But there are patients who aren't. They go, I don't know, the doctor just made it, and you're just sort of like, you realize for them that's not a good feeling, and very often that's why they might switch. The place they have their care, because they're not comfortable with that sense that I don't really know. Someone just told me I had to do this.
Right. we do have a comment from Regan, and it's about parents reading a variety of sources. What do you recommend as reading material for education?
There's so much out there right now. I joke and say patients are on Dr. Google all the time.
Yeah.
At Social Hospital, we actually created an app to help our patients. It's called the Social Hospital Babies app, and on there we've put, a lot of education, things that we hope will be valuable. So I find that's a valuable resource. If the practice you're going to or the hospital offers classes, I really do encourage patients to attend birthing classes. We find only about a quarter of our patients go. For things to read, I think there are valuable books and resources. So I would say talk to your own provider, because certainly what I might like, a lot of patients still like what to expect when you're expecting. But I think online there's a lot of information, and it is challenging at times to discern what's actually valuable versus what sort of hearsay or what someone else thought was important.
Right. Well, that actually leads me to my next question. You and I have talked about this a little bit, about birth plans and how some families or mothers and fathers and partners come in with a particular birth plan, but you're not necessarily sold on the idea of a birth plan, right? You're more about educating and really finding the resources to help you or help parents develop a sense of what they would like to do when they're in the delivery room, right? Can you talk about that a little bit?
Oh, sure. No, absolutely. I think, in a sense, with teen birth, we want you to have some plan. That's the whole preferences section. It doesn't have to be a 52-page plan that's diagrammed out. Some patients do that. That's okay. But if a patient says to me, what should I do? I say, number one, be open-minded, because oftentimes you can't control the situation, whether things go awry with you or with the baby. So kind of have that open-mindedness, trust your healthcare team. You have to believe that we are there to take the very best care of you and your baby. We do not want anything to happen to either of you. So having that faith. And then, it's absolutely fine to explore some little things that might be really meaningful. Like I said, it might be those things about pain relief or no pain relief, or, the immediate bonding with the baby or not. Those are the kinds of things that I think can be very important. So it's not that I tell patients not to make one, but I find sometimes when patients are so fixated and wanting so much control and they lose it, it's very difficult, because then they almost sometimes feel like they've failed themselves. And that's the last thing you want.
Right.
You want them to feel like they have to let their body know what it's supposed to do, listen to it, share it with us, but don't be so, have so much of a plan that if it starts to go in a different direction, that you just can feel like, that they're not doing what they need to do, and sometimes they can't control it.
Gotcha. Melissa says, hi, you were her doctor for her second child. And awesome, that's so great. And Angela wants to know, do you recommend birthing classes for a second baby as well as your first?
I don't think there's any harm in that, because every experience is different. And I think specifically if you might have a particular concern, so whether it's the official class, we also offer things like we have Meet the Midwives night once a month. We have a large midwifery group, and they actually do educational sessions that follow each of those. It's free. Patients can come in, they can meet the midwives, or they can attend an educational session, and there's some interactive time there. So even things like that, where it might not be an official class all day or a series of classes, but to find out, is there an opportunity that you could come in and share your concerns, or kind of hear from healthcare providers, information about birth and things like that.
So getting back to what we were talking about, particularly not having a 52-page birth plan, but I know you had started to talk about what are some of the key things that parents should particularly be thinking about when they come in, when it's time to have the baby. Should they be thinking about pain management, labor preferences, that type of thing, so that they can communicate that to their provider?
Absolutely. I think the big things are, what do you have certain expectations or certain real desires, like about pain relief or not, just so we can help guide you, because we don't want to be walking in and saying, okay, we think you should have an epidural now, and a patient say, well, I really was hoping to do natural labor, or we have a tub that they can use for pain relief. So those are the kind of the things I think for labor that can be helpful. Certainly the method of feeding the baby, we very often will want to know, do you want to try to breastfeed? We offer you support, or do you choose not to? We certainly encourage it, but those are the kinds of things that I think it's helpful to think about ahead of time.
Sure.
At Social Hospital, we really encourage rooming in, so we want the babies in the room with the parents at all times after birth, so to give them that chance to really bond. But like that, it's hard to say exactly what works for women. A lot of women, want to try to utilize, they want to be able to ambulate. They want to be able to try to avoid an induction, like getting put into labor if it's not necessary. And all those things I think are great to think about and try to outline and really discuss with your provider. I mean, having that conversation ahead of time is really nice.
Would you encourage new parents to maybe get a tour of their maternity or labor and delivery where they might have the baby? Is that something that's common or not?
Oh, we do it all the time. I mean, if parents take the class at our hospital, that's part of it. But many parents, especially if maybe they've had another baby somewhere else, it's very comforting to know where to go because, of course, you're in labor.
Yeah. Not feeling so great.
Not feeling so great. And oftentimes the person bringing you in is a little bit stressed as well. So it's very nice if you do kind of the dry run. So we do a lot of tours. And I think patients really enjoy it because they kind of see where they should park, where they can check in, and even to kind of see what the unit looks like. I think it helps give them, again, a sense of sort of that control and that everything's going to be okay. Gotcha. So I do think that can be very helpful. That's
so great. Sheila wants to know, at what week do you recommend birthing classes, and can they ever be taken too early?
I mean, the only challenge I think with something too early is will you remember the information?
Sure.
We usually suggest somewhere around like 32 weeks because by that time, can you go early? Sure. But I think by that time you're getting close enough that the information's valuable. But most women, deliver somewhere 37 weeks plus. So if you take them at, say, 32 weeks, you're typically in that window where, you haven't gone into labor yet and the information is going to remain kind of forefront.
Perfect. And Kara wants to know, she's expecting twins. Congratulations, Kara. And everyone is telling her to expect a C-section. And is that common?
I mean, with twins, I think there's two scenarios. There are some patients who just choose, if they have twins, they would like a cesarean section because they don't want to take any chance of having one baby vaginally and one baby cesarean section. So we certainly will abide by those wishes. Yeah. But if both babies are in the right position, meaning they're both head down, or the first one's head down and the second one is in a position that it could ideally be delivered head down, or at our organization we will do a breech delivery for a second twin. So again, it's the conversation with your own provider and it's your own wish. I have had patients that just say, even though they're both head down, I don't want to take any chances that I have both types of delivery. I'd rather just have a cesarean section on the front end. So,
gotcha.
But I would encourage her, if they're in the right position, to absolutely try to have a natural birth because recovering from that's a little bit easier, especially when you have two new kiddos.
Yeah, so true. Christella has asked for information about getting labor induced. So can you talk a little bit about induction?
Absolutely. So, there's been a lot in the press in the past couple of years talking about, should we be inducing women once they get to 39 weeks and beyond? For most of us that I'd say practice OB, we still feel like labor that begins naturally is the best approach. So we really don't do a lot of elective inductions. We do them for medically indicated reasons or if a patient's overdue. Probably the most common reason is that someone goes past, about a week past their due date, 41 weeks. And then for induction, I mean, there's a variety of methods. Okay. There's lots of things like homeopathic things that, you may hear from your midwife or your doctor that you can do at home. You can drink certain types of tea and do certain activities and eat spicy foods and all of that. Yeah. But as far as for the actual medications that do labor induction, typically we have the conversation with the patient. This is the medication. This is why we're recommending this one. Or, if there's sort of options on medications. With some of them, you could kind of ambulate while the medication's being used, whereas others you have to be on the monitor continuously. So, some of it is those preferences of the patient. Okay. If the patient is someone who adamantly really wants to be able to continue to move, we even do some of our inductions. We'll start them as an outpatient. The patient can come in, kind of get a medication. We watch for a period of time, then they can leave and come back a couple hours later or the next morning. So there's so many options that, again, it's a great conversation with your provider. And I think, again, you want your provider to kind of outline the whys and the hows and make you hopefully feel comfortable about why they're recommending it.
Perfect. We've got some great questions here. Thank you so much. We do want to encourage our folks at home again to send in any questions regarding pregnancy, before, during labor, after. We might have some questions about whether to choose bottle feeding, breastfeeding, care after for the newborn. Send them in. Dr. Deborah's going to do her best. Christina wants to know, after having a C-section with her first child, she'd like to avoid having a C-section again. What is the ideal candidate for a VBAC? And maybe you can talk about what a VBAC is first before we address Christina's second half of her question.
Okay, great. So a VBAC is a patient who's had a cesarean section and she's going to try to have a vaginal birth after cesarean. Okay. So the term we actually use now is before you're successful, you're a TOLAC, you're a trial of labor after cesarean. If you're successful, you had a VBAC. Okay. We've kind of changed the terminology. Either way, we still kind of, we'll say, oh, she's a VBAC.
Okay, gotcha.
But absolutely, our hospital encourages it. There are some small hospitals that don't encourage it only because they don't have in-house and available anesthesia.
Oh, okay.
The one thing you really worry about if you've had a prior cesarean section is that you have a scar on your uterus and that your uterine scar could open up and rupture. And then that's an emergency and you have to have a cesarean section right then.
Okay.
So if a hospital can't support that, they don't offer it.
Okay.
Majority of hospitals, at least in our area, do have in-house anesthesia and doctors,
Okay.
So we have in-house coverage of doctors. We have anesthesia available 24/7. The reason that I encourage the VBAC is the safety piece. Cesarean section is major surgery, so we worry about risks of hemorrhage. And certainly the more times you have surgery, it increases the risk of developing scar tissue.
Mm-hmm.
And what we're starting to see now is this situation where the placenta, which is, the organ that's kind of supporting the developing baby,
Sure.
where it implants on the uterus, if it implants where the scar was, it can potentially kind of grow into the uterus. It's called abnormal placentation. We're seeing more of that.
Really?
As we've seen the cesarean section rise, we've seen the risk of this abnormal placentation occur.
Okay.
And then if that is the case, it requires a repeat cesarean section. And in some cases, women lose a lot of blood and even can go so far as to maybe have to have their uterus removed because the placenta has either grown into the uterus or even sometimes through it. So, we've seen a higher rate of hemorrhage and this abnormal placentation with increased C-sections. So if I have a woman who says, I really want a large family, I have to have a cesarean section, or I had to, but I really want more children, we would absolutely encourage them to, consider trying the vaginal birth after cesarean section so that then they could hopefully have vaginal births and reduce the chance of those other things I mentioned.
Okay. So after having a C-section with her first child, she'd like to avoid the next. So that's, yes.
I think if the baby's head down, and as long as some women had a cesarean section very early, and if they have a scar on their uterus that goes up and down, usually we do a scar like a smiley face.
Mm-hmm.
If the scar on the uterus is in the up and down direction, it actually sort of doesn't allow you to have a VBAC. But again, your doctor would tell you that. So
okay, so that is something, that condition that you were talking about just a few moments ago, that is something that you would identify before she would go in for delivery. You would know right away that the
placenta growing
exactly. Or is it something that you find out in the moment as you're delivering?
You can, but I will tell you, we've gotten much better between the ultrasounds that we use. And I think because if a woman has had a cesarean section, it's almost like you go in thinking, okay, let's make sure that's not happening. Sometimes we do other more, I'd say, not invasive testing, but more high-end testing, like MRI can see it.
Okay.
And a couple of our academic medical centers actually have clinics that just follow women with that condition to really try to, preserve their life and not lead to a lot of blood loss, and in some cases try to keep their uterus, so that the woman could potentially have future children.
So women who have had a VBAC and their recovery, a successful VBAC, what have they said to you afterwards? Like this was so much better than having that major surgery, and the recovery is usually pretty good?
Absolutely. The majority of women say it was so much better because, again, you're not recovering from major surgery and dealing with a newborn. So you're up and around faster. You can get back to your normal activities faster. I mean, most women just feel a lot better. They have less pain, more mobility.
Awesome.
And also, like I said, if they're considering that they'd like a large family, I think it, kind of opens the door for that instead of them feeling like they're limited.
Let's talk a little bit about some of the questions that come up for parents to be as they're exploring having a child. There's always the discussion about, do we want to have an OBGYN? Do we want to have a midwife? Can you talk about the differences between those two key providers and what to expect, whether they choose a midwife or an OBGYN?
Absolutely. So I think a team-based approach is great because oftentimes you have maybe a midwife who's your primary provider, but you always have a doctor kind of in the background. But it is a patient preference. There are just patients who really always want to have a physician, absolutely appropriate. But if I see a patient who I will call low risk, she doesn't really have any medical issues, she's having a singleton, no twins or multiples, I will encourage them to at least consider a midwife and maybe meet one of the ones in our practices because I really do feel like, our midwives, what is their goal? Their goal is to encourage natural births. And I'll tell you, their C-section rate is so low in the patients they follow. Now, granted, they see a select population. They see low-risk women and all of that. But I just find that the relationship they develop, the communication that they foster, I mean, that's the, nature. What does midwife mean? It means with women. So it's like being with the women. And not to say, I'm a physician. I love to think I take good care of women, and I have wonderful physician colleagues. But I do think having that option for women is wonderful. And I find for a lot of women, jokingly say, a lot of the women physicians had midwives deliver their babies. They felt that comfortable with them, their skill set, their, knowledge, but also knew I really don't want to have a cesarean section if I don't have to. So, we'll pursue care.
Yeah.
But I think our model is great because there is always a physician available. So if something changes, the doctor's right there.
And interesting too, in learning more about the Teen Birth Project, I remember speaking to some of the midwives at South Shore Health, and they had said, a lot of the things that were implemented in teen birth, they have already been doing for years.
Oh, that was always
so
the
they
joke.
just sort of felt like this is a no-brainer, right?
Yeah. No, for them, that was, they're like, this is what we always do. And I said, I know, we're just giving it a name now.
Yeah.
We're going to make sure that everyone does this and that we're all,
exactly.
But they have been, some of the biggest champions.
Oh, absolutely. Yeah. You've got some great ones there for sure. Let's talk about the difference between an obstetrician and a gynecologist now. What's that?
So basically, an obstetrician and gynecologist is the same profession.
Okay.
Now so we go through a residency. We come out with obstetrics and gynecology as our skill set. There are some physicians who only practice one of that. So you might say, I have a gynecologist. The other time patients sort of use that is in the office. If they're not pregnant, they say, I don't need an obstetrician. I need the gynecologist. So when they come and see me for a gynecologic problem, they wouldn't say I'm going to see my OB because someone goes, you're pregnant? And they, no, then it's my GYN, if that makes sense. But there are some, like I said, OBGYNs who only now practice obstetrics. They don't do any gynecology.
Okay.
And there are others who don't do any obstetrics. They only practice gynecology. But it's the same specialty. So you're an obstetrician gynecologist by training. That's what we get our board certification in. But I think it's just more of if you're pregnant, you're seeing the OB. If you're not pregnant, you're seeing the gyne.
Okay.
GYN.
So what's a doula?
So a doula is basically a labor support person.
Okay.
Many of them don't have any formal medical training, but they are there to support women in labor. And I will tell you, women who have doulas often do so wonderful because they've got someone who's just really focused on helping them, guiding them through their birth journey.
Okay.
There are some situations where they may not have a support person, or their support person, if someone's like a little bit, I'll say queasy, a lot of times they feel like maybe their partner isn't going to be able to give them the support they need. And that's okay. They identify that on the front end, and they want someone there who they know kind of knows the birth process and can kind of help them with their pain relief. Very often I find women who have doulas are really hoping for natural birth because they want to be able to get through that journey and have someone kind of guide them and give them tools to help them counter.
How does someone even go about finding someone like that?
Oh, there are organizations.
Okay.
Very often I always say whenever a patient says, who's a good doula, I call up the midwives because they seem to have great relationships. But absolutely, online there are lots of organizations of doulas, or it's word of mouth. You may have known someone who said, oh, I used this doula and she's, excellent.
Okay. I do want to encourage folks again to send in their questions to Dr. Dever, anything regarding pregnancy before, during, after childbirth. I'm kind of going to go through a laundry list of questions that I have for you, and you can just kind of go right ahead and answer them as much as you can, as well as you can. Let's talk about epidurals. What exactly is it, and how does it help, or does it hinder the process of childbirth?
I think there's a lot of myths about epidurals. So
Sure.
Epidural is a type of regional anesthesia that's administered during labor, typically. It's a catheter that goes into the lower back, placed by one of our anesthesia colleagues, and it can give continuous pain relief during labor because there's a catheter, it's a very small catheter in the epidural space, and pain medication is administered throughout labor and can be, continuously administered or redosed, that kind of thing.
Okay.
I find for women, if especially they're at sort of a point in labor and they're very uncomfortable, it can oftentimes help labor. They can relax. It can allow the labor to kind of naturally progress. But it's so variable. I always feel bad when a patient says, well, I feel like because I got the epidural, this happened. My labor didn't progress, or,
Right, yeah. I've heard that from other folks, for sure.
But I can say for so many women, it really gives them back that control because they're not in so much pain.
Right.
So it's variable among, many patients. One of my favorite, actually, teen birth stories, we had a patient who had 5 children with us. Great experiences, we joke and say probably she was in the same room with the same providers, but this one was so much better. And one of the reasons was her biggest wish was she wanted an epidural. She had one in one of her early births, then had a number of babies without one.
Okay.
And she thought when she came in, everyone would say to her, well, you did it without one. You don't need one. And for whatever reason, her expectation this time was an epidural. And she felt like with the use of the whiteboard and the communication, everyone abided by that. She got the epidural. She had an amazing experience, and she feels so wonderful about it. But she said, I do worry that if that hadn't been in place, would I have been almost pushed the other way? Like, no, you can do it natural. You don't need that epidural. For her, that, and when we said, well, why was it so important? She said, I don't know. Just this time, I just felt like I wanted it. And she said it just felt like the entire birth experience, everything was in such good control. And, so it almost like empowered her.
I was just going to say that. She had a sense of empowerment there.
And that she was listened to, like right from the get-go. But it gave her that sense. And something, and she was comfortable. She wasn't, obviously labor is uncomfortable, but there was a point in the labor she was uncomfortable. She was able to enjoy the experience of, delivering her baby, which was really very important to her.
Oh, absolutely. Yvonne's comment is about having a 9.4 pound, wow, second child, and having to have an emergency C-section. And we're glad that she and baby are okay, but this is a good chance to talk about how to identify emergency situations. So,
there are so many different ones. I don't want to scare women.
Sure.
But certainly, what are the things that we consider an emergency? Well, if the baby's in distress, majority of times, if we're not doing continuous fetal monitoring, meaning we're putting the belts on the mother's abdomen, where we're tracking the baby's heartbeat, we're listening frequently. So if at any time we think that the baby is in trouble, that sometimes leads to the emergency. So that's kind of the fetal emergency.
Right.
And then there's maternal emergencies. Sometimes the patient is bleeding heavily, and it can be for various reasons.
Okay.
Sometimes that placenta we mentioned earlier can separate. So there's a variety of reasons that women can have heavy bleeding. And sometimes there's other medical conditions, like their blood pressure suddenly is very high, and they're not close to having the baby.
Okay.
There are a number of blood pressure related conditions that actually delivery cures. So we know if we get the baby delivered, the placenta is part of the problem. Once the placenta is out, she'll start to get better. So, those are the kinds of emergencies, that we talk about. Or, the baby's not in the right position, and suddenly the baby's arm is sticking out. And we say that's not going to work.
And what about it just at some point where mom she just can't do it anymore, right?
Oh,
absolutely. Have you ever had situations like that where she's just, it's been wow.
Yeah. And those typically on emergencies. Like there's the emergencies, and like I said, usually the emergencies, it's pretty clear. We're all like, this is an emergency. And,
we're going.
We're going. But it also can be very distressing. Because again, talk about no control. We have these emergency situations where suddenly a lot of people show up because again, everyone has one mission in mind: have that baby. Do it as safely as possible. So that can be very distressing. And in that situation, I think if you were contemplating another delivery, it's really again thinking, okay, would it be better to just have a scheduled birth the next time, even cesarean section, because you're less likely to have that emergency.
Gotcha. Okay. What is umbilical fluid saved? There was a question that had come up about that. Saving umbilical cord fluid, is that something?
I'm assuming they're talking about umbilical cord blood bank.
Probably, yeah.
So, after a baby's born, we always take a sample of the blood and we send it to our lab, really to test the baby's blood type so that we can know for the mom if she needs to get a medication called Rogaine, that kind of thing. But there's a lot out there about should you actually store your baby's blood, and the reason is that the cord blood has stem cells in it, and stem cells have been shown to potentially treat other diseases in your children, in that child or other children in your family. The challenge is, in our state at least, there's not a public cord blood bank, so if you do this, it's something that you have to do on your own money, and for a lot of patients that may not be an option. So we're obligated to discuss it with all our patients. We say umbilical cord blood banking is available, we can provide information. There are these private cord blood banks that will store the blood. I think sometimes if there's family histories of certain diseases, you may want to consider it. Other states do have public cord blood banks where then you could just donate it. Like I said, unfortunately in Massachusetts, for being the medical mecca, we don't have a public cord blood bank. But there are companies, like I said, in other parts of the country.
Are you finding that that's a trend, that more and more families are doing that, or
I think it's pretty steady. I think there's a lot who are educated and choose it, but I don't think it's something I've seen a tremendous growth in. I would like to mention one really cool program that we do at South Shore. We have a placental donation program. So there's a company that will allow you to donate your placenta, and they actually use the membranes to create wound coverings.
No kidding.
It's so amazing. And this doesn't cost anything. So this is what I mean about donating.
Right.
So we have women that, especially right now we've been doing the women who have cesarean sections.
Okay.
That we discuss with them would they consider donating their placenta. There's, paperwork that's filled out. We draw some blood from the mom. And then the company down in Atlanta, they process it. And again, they use the membranes and they create wound dressings.
Oh.
How we found out about it, we have a very busy wound center at Social Hospital.
Sure. Yes,
Social
that's
Hospital.
Right. Yeah.
And one of the wound physicians actually contacted me and said the company, kind of was doing their research about our hospital, found that we have a very busy birthing unit, labor and delivery, do a lot of births. Would you consider teaming up with them and donating placenta? So we've been doing that for the past 2 years now, and it's just been amazing. Again, I think that's such a way of giving back, and that these membranes can go on. They've been used a lot in burn victims, some of the war veterans, who come back with horrible injuries from explosions and things like that, or diabetics. A lot of diabetics get bad wounds.
Sure.
So it's really been, I just think that's such an amazing thing.
Sure.
So
That's
if you can't
fascinating.
donate your cord blood, you can donate your placenta.
Right. Are there other hospitals in the Boston area that are also doing it that you know of? Or
I think there's a few that they're having conversations with. We were the first. We've been the first at a few
Yeah,
things, which
we
is
have
fun.
been, right?
But I think being an independent hospital, we have that flexibility.
Sure.
You know, there's not a lot of red tape. You know, usually administration's very supportive of things if it makes sense and, you know, there's good
Right.
science behind it.
Right. So again, discuss it with your provider beforehand and see if that's even an option,
Yeah.
right? Wonderful. All right. So last question for the night is if you had any advice for parents to be, how to plan and what to think, and this is a beautiful experience, right? What would you recommend to them in planning?
Yeah, no, like I said earlier, I think the most important thing is feel comfortable with your provider, have those open conversations. And for labor, I mean, try to be open-minded about it. Understand that, you know, again, the team taking care of you has you at the forefront. They want you to be healthy, they want your baby to be healthy, and hopefully the discussions, the conversations, the recommendations are all to get to that goal. But really try to go in, you know, understanding that you'd like plan A, but sometimes plan B comes along. But if it comes along, there's a good reason and that they can explain it to you and involve you in that conversation.
Fantastic advice. Thank you so much for joining us today, Dr. Dever. I really appreciate it. We
Thank
want to
you.
thank all our viewers at home who have been watching. If you didn't get a chance to watch this entire segment of Facebook Live, you can watch it on onehealthyboston.com. We hope that you'll tune in. And we thank everyone for joining us. We'll catch you again next month for our next topic, right?
Thanks, Kristen.
Thank you.